Hello everyone. Today we had an interesting case which came to OP with complaints of pain in right hip region. Patient had alleged history of slip and fall from stairs yesterday at around 9:30 p.m. Since then, patient complained of pain in right hip region. So we have shifted the patient to radiology and we have carried out X-rays. So we have performed X-ray pelvis with both hips AP view, and also we have carried out traction with internal rotation view. So we have identified that the patient has intertrochanteric fracture. You can see that there is fracture present at the intertrochanteric region. So this is the greater trochanter, this is the lesser trochanter. So we have admitted the patient and we have kept the patient on skin traction. We have applied a weight of around 3.5 kgs. So let's learn now more about the intertrochanteric fracture. So basically about the intertrochanteric fracture constitutes about 50% of fractures of proximal femur. Ratio of men is to women are at a ratio of 2.2:1 to 8:1. Women are more commonly affected. This is because of their postmenopausal metabolic changes in bone as age is advancing, and also osteoporosis fragility fractures also can occur. Next comes is anatomy. Intertrochanteric fractures are usually extracapsular, occur in cancellous bone with abundant blood supply. So as there is abundant blood supply, chances of non-union and osteonecrosis is less problematic than that of neck of femur fracture. Now, next learn about classification. So in intertrochanteric fracture, there are two types of classifications. One is Boyden-Griffin classification. In Boyden-Griffin classification, there are four types. In first type, it is stable IT fracture. Second type, you can see that there is comminution present. So it is unstable comminuted type. This is the third type. In third type, you can see reverse oblique pattern. In fourth type, you can see comminuted with subtrochanteric extension. So this is Boyden-Griffin classification. Next comes is Evans classification. In Evans classification, in type 1, you have undisplaced two-part fracture. There is no displacement. In type 2, you can see that there is displacement, two-part fracture. In type 3, displaced three-part fracture with posterolateral comminution. So here GT is involved. So in type 4, displaced three-part fracture with large posteromedial comminuted fragment. Here you can see lesser trochanter is involved. So in type 5, four-part fracture. So greater trochanter is one part, lesser trochanter is one part, femur shaft is another part, and this is another part. So this is about Evans classification. Next comes is deforming forces. So deforming forces are primarily caused by muscles. So because of these deforming forces, they cause shortening, external rotation, and varus position of the limb. So even this patient also had same complaints. On examination, we had on inspection there was swelling present, and we also saw that the hip was in neutral position, knee was in extension, and lateral border of the foot was touching the couch. And so we have corrected that through skin traction by keeping the limb in neutral position. That's what I have shown you about the skin traction picture. So abductors displace the greater trochanter laterally and proximally. Iliopsoas displaces the lesser trochanter medially and proximally. Hip flexors, adductors and extensors pull the distal fragment proximally. So basically the stability in intertrochanteric fractures depends upon the medial cortex. If the posteromedial cortex is intact, then it indicates it's a stable fracture. If the posteromedial cortex is lost, it is an unstable fracture. Next comes is mechanism or mode of injury. In young individuals, it occurs because of a high energy injury, usually either through RTA or accident, anything. In older, it occurs because of a simple fall. Most of the fractures result in direct impact to greater trochanteric area. So patient usually comes with complaints of pain in the groin region, inability to move the limb, swelling in the region of hip, leg in short and externally rotated. All these were seen in this patient, and there was also tenderness present over greater trochanteric area. Next, radiographs. X-ray pelvis with both hips with AP view, and also in the affected limb traction and internal rotation. I have already also shown you the X-ray of traction and internal rotation. We have You might be having a doubt why we have carried traction and internal rotation view to see the pattern of fracture. MRI is study of choice in cases of occult fracture which are not apparent on plain radiographs, and CT is performed in cases where MRI is contraindicated. So let's learn something about basic cervical fracture. Basic cervical fracture is actually a pattern of neck of femur fracture, but as it is located proximally or along the intertrochanteric line, but it is extracapsular, so it is similar. It is always treated similar to intertrochanteric fractures. Next comes this reverse oblique pattern of fracture. So in reverse oblique type of fracture, as we have already told you, that in reverse oblique fracture is usually unstable. In classic intertrochanteric fracture, you can see that the fracture line is extending from greater trochanter to lesser trochanter. This is the fracture pattern. But in reverse oblique fracture, you can see that there is fracture pattern extending from lesser trochanter to greater trochanter. So reverse oblique fracture is characterized by oblique fracture line extending from medial cortex proximally to lateral cortex distally. This fracture is treated as subtrochanteric fracture. Next comes this treatment option. In treatment, our main aim is to maintain normal neck shaft angle during union. So it is possible by two ways, either through conservative management or through internal fixation. Conservative management is usually by skin traction, and it is not preferred in elderly patients as a definitive line of management, because prolonged bed rest, like for around 3 to 4 months, patient can land up in bed sores and pneumonia. So we have to fix this fracture. So we can fix the fracture either by extramedullary or intramedullary. Extramedullary was dynamic hip screw. So this is nothing but this is dynamic hip screw. Okay. Also, other ones are dynamic condylized screw, 95 degrees fixed angle condylized screw with side plate, angle bladed plate. So this is your condylar plate with 95 degrees, and this is an angle bladed plate. So this is angle bladed plate. Next comes is intramedullary devices. Intramedullary devices are cephalomedullary nailing. Cephalomedullary nailing is nothing but, this is your cephalomedullary nailing. This is nothing but intramedullary nail along with that sling hip screw. It's a combination of intramedullary nail and sling hip screw. But now, which is commonly used method which we use here is closed reduction internal fixation with proximal femoral nailing. So this is closed reduction internal fixation with PFN. So next comes is, these are the treatment options. So next comes is complications. So complications are loss of fixation, non-union, Z effect. In Z effect, proximal screw penetrating into the hip joint and distal screw backing out of the femoral head. So in Z effect, what happens is, this is the proximal screw. So this proximal screw goes inside the hip joint, whereas the distal screw comes backing out. So this is known as Z effect. So it is one of the complication. Malrotation deformity and osteonecrosis of the femoral head. So these are the complications of the intertrochanteric fracture. I hope you liked the video. Enjoy. Take care. Bye bye.